Good afternoon. Thank you all for joining us on another session of Cuddles online neonatal education. Today we shall be discussing about calcium metabolism and calcium-related disorders in newborn babies. Physiological importance of calcium cannot be underemphasized. We know that calcium is associated with a lot of vital functions in the body. To name a few, calcium salts in bone provided structural integrity to the skeleton. Calcium ions in extracellular as well as in the cellular fluids are essential for normal functioning of various biochemical processes that require calcium as a second messenger. It is also important for control of neuromuscular excitability for synaptic connections. Calcium also does play a very vital role in blood coagulation. So there are a lot of calcium sort of dependent enzymes that are vital in playing a role in blood coagulation. Calcium plays an important role in secretion of various hormones as well as in regulation of function of enzymes. Now, if you look at circulating calcium fractions in the body, there are multiple fractions in which calcium exists. So the most and possibly the abundant formation or form of calcium that is available in the body is ionized or free calcium. This is also important because it is biologically active and is vital in all the functions that we just discussed. In addition, calcium is also found in a form where it is bound with phosphate, bicarbonate, and citrate. So this is called as the bound fraction of calcium. And another 40% of calcium exists in the protein-bound form. So all these fractions are important for us to understand and to further infer the function of each of these fractions. The protein-bound fraction of calcium, although it accounts for 40% of the total calcium, is a biologically inactive form and it is not excreted from the body. So the normal level of total calcium, which is said to be between 7 to 10 milligrams per deciliter in a preterm baby and between 8 to 11 milligrams per deciliter in a term baby, can also be expressed as millimoles per liter. So it is between 2.2 to 2.6 millimoles per liter when expressed as total calcium, out of which roughly 50% exists as ionized calcium. So the ionized calcium levels range between 1.1 to 1.3 millimoles per liter in the body. Calcium disturbances can either be due to changes in the total level of calcium or its distribution in different compartments. So measurement of ionized calcium is particularly relevant if we are dealing with alkalosis, hypoalbuminemic states, and acidosis. This is because the pH of the body changes the proportion of calcium that exists in the ionic form or the free form. Likewise, in conditions where there is hypoproteinemia or hypoalbuminemia, although total calcium and protein-bound calcium fraction can be low, ionized calcium levels are relatively preserved. It is important to adjust for total calcium whenever we are dealing with hypoproteinemia. Calcium level reduces by 0. milligrams per deciliter for every 1 gram per deciliter reduction in albumin levels. So corrected calcium can be expressed by the formula total calcium plus 4 minus albumin into 0.8 milligrams per deciliter. We have already discussed the physiological roles of calcium. It is also important to remember that there are multiple hormones that regulate calcium levels in the body. These are parathormone or PTH, vitamin D, parathormone-related peptide, calcitonin, and calcium sensing receptors. Parathormone is one of the most vital hormones that regulates calcium levels and calcium metabolism in the body. It regulates bone resorption of calcium and phosphorus as well as phosphate excretion from the kidney. Renal calcium and magnesium reabsorption is promoted by parathormone. In addition, parathormone increases the activity of 1-alpha hydroxylase enzyme in the kidney and hence increases the total level of 1,25-dihydroxycholecalciferol or calcitriol levels. This happens by around 48 hours of life by increasing the activity of the enzyme 1-alpha hydroxylase. At very high serum concentrations, PTH causes bone resorption and promotes intestinal absorption of calcium as well as phosphate. PTH regulates calcium by its action on target cells in bone and kidney that express the PTH-related peptide or type 1 PTH receptor. So this figure summarizes the various actions of parathormone. When low calcium levels arise in the blood, this results in reduced activation of the calcium sensing receptor, which results in increased formation or release of the parathormone hormone from the parathyroid gland. Parathormone helps by increasing calcium absorption from the tubules, but it promotes phosphate excretion from the renal tubules. So it has diametrically opposite effects on calcium and phosphorus on the renal tubules. It promotes calcium reabsorption, but it decreases phosphorus reabsorption and actually promotes phosphorus excretion from the renal tubules. On the bone, parathormone works by increasing calcium release from the bone, and by its action on both bone as well as on the kidney, parathormone effectively helps in restoring or normalization of serum calcium levels. Parathormone is also essential for increased conversion of 25-hydroxy vitamin D to 1,25-dihydroxycholecalciferol, which is the active form of vitamin D, which also helps in assisting calcium absorption from the gut. And all these actions result in normalization of calcium levels. The hormone that works in a diametrically opposite fashion to parathormone is calcitonin, which is its physiological antagonist. Calcitonin is secreted from the parafollicular C cells of the thyroid gland. It decreases bone resorption and hence decreases the release of calcium from the bone. It also reduces gastrointestinal absorption of both calcium and phosphorus and increases renal calcium and phosphate excretion. So by all these actions, calcitonin reduces the serum calcium levels. So PTH regulates calcium by its action on the target cells in bone and kidney. We already discussed this by cells that express the PTH-related peptide. So effectively in the body, the calcitonin and PTH, which have diametrically opposite actions, as well as calcitriol or active vitamin D, all act together. So when calcium levels go up too high, the thyroid gland releases calcitonin, which kind of decreases calcium reabsorption from the urine and decreases GI calcium uptake, as well as it promotes calcium deposition in the bones, effectively reducing the calcium levels. On the other hand, when calcium levels fall down too low, then parathormone secretion is increased, which results in elevating calcium levels. So the calcium concentration in utero is generally higher. So this is because of the passive transport of calcium and phosphorus across the placenta. 80% of calcium accretion during the pregnancy or across the placenta occurs during the last trimester, so which is after 28 weeks. And this is one of the reasons why preterm and very low birth weight newborns can have inherently low calcium levels, because they miss the most active phase of calcium accretion across the placenta. Transport of bone minerals, that is calcium and phosphorus across the placenta, results in higher concentration in the fetus when compared to the maternal levels. Active transport across the placenta is facilitated by the transmembrane calcium sensitive channel TRPV6, calbindin, and plasma membrane calcium ATPase. On the other hand, PTH and calcitonin do not cross the placental barrier. Parathormone-related peptide regulates calcium balance in the placenta. Serum levels of phosphate, parathormone-related peptide, and calcitonin are greater. Now, while 1,25-hydroxycholecalciferol and PTH are lower in the fetus compared to the maternal levels, levels of 25-hydroxy vitamin D3 in the fetus approximate that in the mother. After birth, because the newborn is abruptly cut off from the placenta, the newborn becomes reliant on dietary intake of calcium absorbed from the GI tract and skeletal calcium. So there is a gradual decline in the serum calcium levels as the baby transitions from fetal life into the neonatal life. And hence, in the first 24 to 48 hours, the parathyroid glands will gradually start responding to the decreased levels of ionized calcium and start secreting more PTH. In the newborn, after the baby is born, because of the relative fall in serum calcium levels, PTH will increase, whereas parathormone-related peptide and calcitonin levels will decrease in the first 48 hours of life. This will gradually normalize once PTH levels manage to normalize the serum calcium levels. So at birth, the umbilical serum calcium levels are generally high at 10 to 11 milligrams per deciliter, whereas by 24 to 48 hours, most newborn babies, the calcium level would drop to 7.5 to 8.5 milligrams per deciliter. So now what is hypocalcemia? So hypocalcemia is defined as either reduction in total serum calcium concentration to less than 7 milligrams per deciliter, or an ionized calcium concentration of below 1 millimoles per liter or 4 milligrams per liter. Now, in very low birth weight infants, ionized calciums are physiologically between 0.8 to 1 millimoles per liter, and these are quite common and they are not associated with clinical symptoms. Even calcium levels as low as 0.7 millimoles per liter are not usually associated with seizures in VLBW infants, whereas in larger infants, seizures may occur more readily when the ionized calcium drops to 0.8 to 1 millimoles per liter. So these are all some broad causes for hypocalcemia. I'll skip the slide because we'll be discussing this in a little bit more detail. A little bit about calcium sensing receptors. So when there is a autosomally dominantly inherited gain of function mutation of the calcium sensing receptor, then the clinical presentation can be in the form of hypocalcemia. So this is because the calcium sensing receptor can become hyperactive, leading to suppression of the PTH function. There can be also hypercalciuria in this condition. Thiazides can be considered for control of hypercalciuria in this particular mutation, whereas when there is a loss of function mutation of the calcium sensing receptor, which is again inherited in an autosomal dominant fashion, the baby may present with a hypercalcemia and hypocalciuria, and the treatment of choice would be calcimimetics. There are some rarer syndromic causes of hypothyroidism, like charge syndrome, which is 22q deletion, also called as 22q deletion syndrome, which is also called Dijous syndrome, or with charge syndrome, or with some other conditions like autoimmune polyglandular syndrome type 1. Hypocalcemia or hypoparathyroidism can also be a part of hypoparathyroidism, sensory neural deafness, and renal dysplasia syndrome, as well as a few mitochondrial cytopathies. So in newborns, hypocalcemia can be broadly classified into early onset versus late onset hypocalcemia. Early onset hypocalcemia, as defined as hypocalcemia seen within the first 72 hours from birth, is usually because of fetal or neonatal factors, prematurity, low birth weight, SGA and IUGR babies, babies who have had perinatal asphyxia, hypomagnesemia, neonatal sepsis or renal failure, and secondary to maternal factors like maternal diabetes, vitamin D deficiency, toxemia of pregnancy, and maternal hyperparathyroidism. It is important to note that preterm babies born before 32 weeks of gestational age must be routinely supplemented on calcium if they have to be begun on IV fluids for any reason. This is because of the high risk of developing early onset hypocalcemia. Likewise, the other at-risk group of newborns, like a newborn with perinatal asphyxia, or a sick baby born to a mother with diabetes mellitus, or a baby who is SGA who also happens to receive IV fluids for some reason. In all these babies, it is better to start with a prophylactic supplementation of calcium. Usually, we begin 4 to 5 ml per kg of 10% calcium gluconate in all these babies as a part of their intravenous fluids itself. On the other hand, late onset hypocalcemia often presents after 72 hours from birth, and this is generally not because of inherent fetal or neonatal factors. Late onset hypocalcemia is usually because of an identifiable nutritional or a biochemical deficiency, such as dietary deficiency of calcium intake or increased dietary phosphate provision. Neonatal vitamin D deficiency, hypomagnesemia can also be associated with late onset hypocalcemia. Significant hyperbilirubinemia requiring phototherapy, as well as hypoparathyroidism and hormone resistance, can all be important causes for late onset hypocalcemia. So although it may be reasonable to not do a very detailed evaluation for most newborns with early onset hypocalcemia, it may be more appropriate to undertake complete evaluation for newborns who present with late onset hypocalcemia. So, which are all the newborns who require screening for hypocalcemia? So, based on the risk factors for early onset hypocalcemia, we can identify that the following group of newborn babies require screening for calcium levels. These include preterm neonates, particularly neonates born below 32 weeks of gestational age, small for gestational age newborns, defined as newborns with their birth weight centile below 10 centile for expected for that gestational age, newborns with intrauterine growth restriction, infants with 1-minute Apgar score below 4, infants of diabetic mothers who are sick who require NICU admission, infants with underlying sepsis, Extreme low birth weight infants would automatically get screened as part of the broader window of preterm neonates. Ionized calcium should be monitored at 12, 24, at 48 hours. Ideally, most of us may prefer to do at least one level of ionized calcium, if not undertake all these three levels. For newborns born less than 32 weeks or preterm babies born between 1,000 to 1,500 grams, ionized calcium can be checked at 24 and 48 hours of life, respectively. Any infant with symptoms consistent with hypocalcemia should also be screened. These may include symptoms such as jitteriness or hyperexcitability or seizures. We should be seeing the clinical symptoms in detail. And calcium monitoring, in case calcium levels are low or abnormal, must be continued until the levels normalize and until dietary, oral, or enteral intake is completely established. So, when one screens for the at-risk babies for hypocalcemia by performing a serum calcium and ionized calcium, and if one does confirm the presence of hypocalcemia, defined by either the total calcium levels which are below 7 milligrams per deciliter or ionized calcium levels less than 1 or 0.8 millimoles per liter based on the gestational age, one would further undertake workup in the form of phosphorus levels, magnesium, PTH hormone levels, and 25 hydroxy vitamin D levels. So if one finds that the baby has low phosphorus levels increased, accompanied by low levels of 25 hydroxy vitamin D, and along with high levels of PTH, this is usually because of dietary vitamin D deficiency, and this can be something that is easily correctable with supplementation of appropriately high doses of vitamin D. So usually in newborn babies with vitamin D deficiency or insufficiency, we supplement 2,000 international units of vitamin D daily until around 12 weeks. On the other hand, if you find normal or high levels of phosphorus in a newborn with hypocalcemia, one considers the possibility of hypoparathyroidism. Now, if this level is accompanied by high PTH level, then this is possibly indicative of pseudohypoparathyroidism, which is because of parathyroid hormone receptor resistance or because of renal failure, where we often see this combination of hypocalcemia with high phosphorus levels along with secondary hyperparathyroidism. This situation can also occur when there is increased phosphorus load in the formula. This used to happen with earlier generation formulas or in babies with predominant cow milk based feeding. On the other hand, if we are seeing that hypocalcemia is accompanied by low levels of PTH, for that matter, even normal levels of PTH in the presence of documented hypocalcemia would prompt us to consider the diagnosis of hypoparathyroidism. This can occur either in isolation or can be a part of genetic conditions like Digeorge syndrome, maternal hyperparathyroidism, and transient hypoparathyroidism because of acute illnesses or maternal diabetes. So what are the clinical features of hypocalcemia? Now, early onset hypocalcemia in the first 72 hours after birth is usually asymptomatic. There may be occasional neuromuscular hyperexcitability that can manifest, like the baby can have tremors or jitteriness. Whereas late onset hypocalcemia is usually symptomatic. The symptoms can be in the form of neuromuscular excitability, jitteriness, jerking, tremors, hyperacusis, or seizures, or the baby can have non-specific signs such as apnea, cyanosis, reduced feeding, lethargy, tachycardia, or signs of congestive cardiac failure. Inspiratory stridor due to laryngeal spasm or wheezing due to bronchospasm is also reported secondary to hypocalcemia. Sometimes the baby may also develop vomiting because of pyloric spasm. So once one suspects hypocalcemia, one would confirm it by getting the total calcium levels with or without ionized calcium levels. So based on the baby's gestational age or maturity, the definitions or cutoffs for defining hypocalcemia based on total calcium levels and ionized calcium levels are different, as has been shown in this slide. Based on the setting or scenario, one has to assess for various possible aspects in the history as well as clinical examination that can be indicative of the possible etiology for hypocalcemia. Most of these may not be relevant for newborn babies, but in children with hypocalcemia, some of these aspects in history might be relevant. For example, history of surgery, which can potentially impact the parathyroid function. For example, surgery performed on the thyroid gland or irradiation for thyroid. or history suggestive of candidiasis, which can indicate some syndromes where hypoparathyroidism can coexist with candidiasis. So autoimmune polyendocrine syndrome type 1 can be a potential etiology when there is history suggestive of candidiasis. We also would want to know if there is history to suggest any excessive phosphorus load to the baby, such as risk of tumor lysis or rhabdomyolysis, which can explain complications related to high phosphorus. History of obesity or learning disability, which can also point towards potential contributors to the clinical picture. Assessment of maternal conditions that could impact calcium, such as maternal hyperparathyroidism. Family history of hypocalcemia for genetic causes of calcium metabolism defects, and failure to thrive polyuria, which can be potential causes of hypocalcemia in some tubulopathies like Barter's syndrome, and neonatal history of hypocalcemia for those factors or etiology that can have the onset from the neonatal phase. In physical examination, physical findings that suggest cleft lip or cleft palate or dysmorphism can point towards syndromic causes like Dijorge syndrome. Alopecia can be a component of vitamin D dependent rickets type 2. Cataract can be seen in some causes of hypoparathyroidism or pseudo-hypoparathyroidism. Cardiac defects associated with hypocalcemia. This can be a very, very important indicator of Dijorge syndrome, as well as seen in HDR syndrome. Deafness can be seen again accompanying hypoparathyroidism or pseudo-hypoparathyroidism. And typical facial features of dysmorphism in the form of round facies, brachymetacarpia can also be seen with pseudo-hypoparathyroidism. So these are all some specific physical findings. If one finds hypertension, then one needs to think of renal etiology like chronic kidney disease, which can explain hypocalcemia, secondary hyperparathyroidism, as well as hypertension. So having confirmed the presence of hypocalcemia and having looked into the detailed history and physical examination, what are all the investigations that one needs to consider? So these are the level 1, level 2, and level 3 investigations in a documented case of hypocalcemia. The need for all these investigations should be very carefully individualized based on the clinical setting. Of course, any baby with suspected hypocalcemia will need confirmation by doing a serum calcium and ionized calcium levels. So we already discussed based on the gestational age, what would be the cutoff to term or to detect hypocalcemia. Apart from calcium levels itself, the other very vital first level investigations in documented hypocalcemia will include serum phosphorus, alkaline phosphatase, creatinine, electrolytes, albumin, and magnesium. Serum phosphorus, especially when phosphorus is high in presence of hypocalcemia, will point towards two important broad etiology. One is parathormone defects like hypoparathyroidism or pseudo-hypoparathyroidism. Likewise, phosphorus can also be elevated with renal causes of hypocalcemia. So these are two important broad groups that we need to remember when you see hypocalcemia with hyperphosphatemia. Now, creatinine and electrolytes help us to further differentiate whether this is a renal cause for hypocalcemia. So elevated creatinine, elevated phosphorus, along with low calcium, takes it more likely towards renal cause for hypocalcemia as seen in chronic kidney disease. Electrolytes can also be useful in this particular situation where we may see hyponatremia or hyperkalemia. Serum albumin levels, as already discussed, in a newborn with hypoalbuminemia can explain total levels of calcium that are low, but ionized levels of calcium can be relatively normal. Hypomagnesemia is another treatable cause for hypocalcemia because magnesium critically determines the parathormone gland hormone secretion. In the second level of investigations, one considers getting X-ray wrist for features of rickets and ECG to look for long QT syndrome, as well as the hormonal workup in form of parathormone and 25-hydroxy vitamin D. Now, it is to be remembered that the most stable form of vitamin D that can be assessed in lab test is the 25-hydroxy form of vitamin D, although this is not the biologically most active form of vitamin D. The active vitamin D, which is 1,25-dihydroxycholecalciferol or calcitriol, is unfortunately not a stable compound and hence is not very amenable for lab testing. The other investigations that may be also required in level 3 testing of hypocalcemia would include liver function test, a chest X-ray for thymic shadow or cardiac disease, as may be useful in a case of Dijorge syndrome, maternal bone mineral calcium profile, So this can be handy in either maternal vitamin D deficiency, where we will see hypocalcemia and low phosphorus, or in cases of hyperparathyroidism in mothers that can lead to transient hypoparathyroidism in the baby. Lastly, genetic tests for some genetic causes of hypocalcemia need to be considered. So these are the cutoffs for different commonly done level 1 and level 2 tests. I shall be discussing particularly the hormonal assays. Vitamin D, 25-hydroxy vitamin D, the normal levels are 20 to 100 nanograms per ml, and levels below 20 nanogram per ml usually suggest hypovitaminosis D. Parathermone, the normal levels are between 10 to 66 picogram per ml. So in general, if there is hypocalcemia due to dietary calcium or vitamin D deficiency, we expect parathermone levels to be elevated. Usually it is above 100 or 150 picograms per ml. Elevated PTH usually suggests either the presence of PTH resistance or hypovitaminosis D, whereas a low PTH with hypocalcemia will suggest that the baby has hypoparathyroidism or hypomagnesemia. The other investigations which we discussed were alkaline phosphatase, active vitamin D, and spot urine calcium creatinine ratio. Now, higher calcium creatinine ratio might suggest hypercalciuria. So how do we treat hypocalcemia is the next aspect of this presentation today. The acute management of hypocalcemia can be divided into management of asymptomatic or symptomatic newborns. In asymptomatic newborns with calcium detected to be low on routine screening can generally be corrected with calcium supplementation. If the baby is already on full enteral feeding, we may simply supplement oral calcium at 50 mg per kg per day of elemental calcium. This is with context of a term healthy newborn. If the baby is a preterm or very low birth weight newborn, the calcium supplementation would be much higher, usually 120 to 200 milligrams per kg of elemental calcium. If the baby is on intravenous fluids or parenteral nutrition, then the baby would need to be given 10% calcium gluconate added to the solution. In case of asymptomatic hypocalcemia, we generally would start with 7 to 8 ml per kg per day of 10% calcium gluconate. If the baby has symptomatic hypocalcemia in the form of signs of neuromuscular excitability or seizures, then the baby would generally require IV calcium gluconate correction. This is all the more relevant, especially in babies with symptom in the form of seizure. IV calcium gluconate, a bolus is generally recommended at 1 ml per kg, given slowly as an infusion over 10 minutes, ensuring that the baby's heart rate is recorded electrographically using ECG leads. This can be repeated if required, if the baby continues to have symptoms. And this must be followed up with a continuous infusion of elemental calcium to try and give at least 50 mg per kg per day of enteral calcium. So if we are using 10% calcium gluconate for maintenance calcium correction as well, 1 ml of calcium gluconate has 9 milligrams of calcium. So we may have to give around 5 to 8 ml per kg per day of 10% calcium gluconate. In cases of hypovitaminosis D, vitamin D supplementation is begun at the dose of 2000 international units daily for a duration of 6 to 12 weeks, followed by a maintenance dose of 400 international units daily. Alternatively, active vitamin D or calcitriol can be used at 0.08 to 0.1 micrograms per kg per day. When ionized calcium levels drop to less than 1 millimole per liter, usually for infants more than 1,500 grams or to less than 0.8 millimoles per liter for very low birth weight infants, then continuous IV calcium infusion should be considered, irrespective of whether the baby is symptomatic. However, ionized calcium is not routinely done in clinical practice unless and until the baby requires blood gas assessment for other clinical indications. If cardiovascular compromise is present, then it is better to maintain ionized calcium between 1 to 1.4 millimoles per liter or 1.2 to 1.5 millimoles per liter in a larger infant. Again, for active seizures or profound cardiac failure, 100 to 200 milligram per kg of 10% calcium gluconate can be given as a continuous intravenous infusion. Monitor heart rate and cardiac rhythm as well as infusion site for extravasation throughout the infusion. If there is no clinical response, the bolus dose of calcium may be repeated after 10 to 15 minutes. We shall now discuss a little bit about hypercalcemia. Hypercalcemia is defined as the presence of total serum calcium levels that are more than 11 milligrams per deciliter or ionized calcium levels beyond 1.45 millimoles per liter. It may be asymptomatic or can rarely be symptomatic. Most of the times, hypercalcemia is asymptomatic and is discovered incidentally during routine screening. Severe hypercalcemia is defined as calcium levels more than 16 milligrams per deciliter. The etiology for hypercalcemia is usually because of imbalances in intake of calcium, extreme prematurity, clinical adjustments of TPN by completely removing phosphorus or abnormal calcium phosphorus ratio while providing parenteral nutrition, hyperparathyroidism. It can be associated with maternal hypoparathyroidism or secondary hyperparathyroidism as seen in renal etiology as well as seen in acute renal failure. Hypercalcemia may also be seen with hyperthyroidism, hypervitaminosis D, hypophosphatemia, autosomal recessive bone dysplasia, decreased renal calcium clearance, familial hypocalciuric hypercalcemia, which is a mutation that is autosomal dominantly inherited, idiopathic neonatal or infantile hypercalcemia as a part of Williams syndrome, where the child would also have supravalvular aortic stenosis and Elfin phases. As we discussed, hypercalcemia may often be asymptomatic, but sometimes we may see some clinical features such as hypotonia, encephalopathy, poor feeding, vomiting, polyuria, and constipation may be seen in bigger children. Hepatosplenomegaly and anemia may also be there. Extraskeletal calcifications or nephrocalcinosis may be picked up when we do ultrasound screening, and the baby may present with feeding difficulties or poor lineal growth. So in cases of suspected or confirmed hypercalcemia, one would elicit history suggestive of maternal or family history of the same parathyroid disorders, history or previous reports to suggest nephrocalcinosis, or if the baby had been a preterm who required NICU admission and TPN, we would look into the calcium phosphorus ratios or manipulations of these calculations in parenteral nutrition. Physical examination would be focused on seeing whether the baby is SGA, whether the baby has craniotabes or fractures. This can be seen in hyperparathyroidism. And characteristic Elfin phases, which would be seen in Williams syndrome, presence of cardiac murmur, again for Williams syndrome, supravalvular aortic stenosis, or peripheral pulmonic stenosis seen with the same condition. Indurated bluish-red lesions can be seen with subcutaneous fat necrosis. Investigations in hypercalcemia would be focused to find the possible etiology. So serum and urine mineral levels of phosphorus. So if you have hyperparathyroidism, obviously the serum phosphorus levels will be decreased, whereas urinary phosphorus levels will be increased. Likewise, urinary calcium creatinine ratio, if it is suggestive of hypocalciuria or decreased urine calcium creatinine ratio, can explain hypercalcemia. Low serum phosphorus level is seen with phosphate depletion, hyperparathyroidism, or familial hypocalciuric hypercalciuria. Radiography can be helpful where we may see evidence of demineralization or subperiosteal resorption in hyperparathyroidism. In hypervitaminosis D, we may see submetaphyseal rarefaction. Treatment of hypercalcemia is relatively straightforward. One discontinues all dietary sources of calcium intake if ionized calcium straight away is more than 1.8 millimoles per liter. Volume expansion is useful with isotonic saline solution. One should promote hydration and try to increase urinary calcium excretion. If cardiac function is normal, it is a good idea to give 10 to 20 ml per kg bolus of normal saline over 30 minutes. And one may give furosemide 1 milligram per kg, which induces urinary calcium excretion. Inorganic phosphorus supplementation may also lower serum calcium levels in hypophosphatemic patients. Glucocorticoids are effective in hypervitaminosis A and D by increasing the renal calcium excretion. And in severe cases, one may have to consider giving calcitonin or parathyroidectomy with autologous reimplantation. So this is something on the ECG changes with calcium imbalance. So normally in hypocalcemia, we expect that the ST segment is lengthened. This is accompanied by prolongation of the QT interval as well. So we know that QT is the interval that starts from the beginning of the Q wave till the end of the T wave. Now, although QT interval prolongation is seen in hypocalcemia, this is relatively non-specific because this can also be seen with some congenital syndromic conditions like long QT syndrome. Hence, to kind of detect whether this is secondary to hypocalcemia versus other reasons, one also would look at the ST segment. If the ST segment is also lengthened, then it is most likely QT prolongation because of hypocalcemia. The reverse is also true. QT interval is shortened in hypercalcemia. So how do we say whether the QT interval is normal or prolonged? So in general, instead of just looking at the QT interval, it is good to look at QTC or corrected QT interval, which corrects for the variations in the heart rate, such as tachycardia and bradycardia, which can influence the length of the QT segment. So corrected QT segment or QTC is given as QT divided by root of RR. Apologies for the lack of the square root symbol. It must be QT divided by root of RR. RR is the distance between the R wave into subsequent waveforms. So for example, if the interval between the R waves in a certain baby's ECG is equivalent to around 20 small squares, each small square represents 0.04 seconds. So we'll multiply 20 into 0.04, which gives us 0.8. So if you divide the QT interval divided by root of 0.8, that gives us the QTC or corrected QT interval. So based on this calculation, a QT interval more than 0.45 seconds until 6 months and anything more than 0.44 seconds above 6 months is considered to be prolonged QT interval. So these are the recommended dietary allowance for calcium intake for infants, children, and adolescents. And this is the calcium content that is seen with different types of animal milk. Note that the cow's milk has increased content of phosphorus and therefore an unfavorable ratio of calcium to phosphorus intake. So with that, I thank you all for joining us for today's session. And please feel free to post your comments or questions in the chat box.